नमस्ते सबैलाई। आज हाम्रो नलेज क्याफे रेजिडेन्ट राउन्डको अर्को राउन्डमा आज हामी थाइरोइड डिसअर्डरको बारेमा थोरै चर्चा गर्छौँ र यसको बारेमा प्रेजेन्ट गरिदिन र डिस्कस गरिदिनु हुन म राजु गुरुङलाई यो फ्लोर ह्यान्डओभर गर्छु। राजु। डाक्टर राजु।
हेलो।
हजुर।
सुन्या छ?
हजुर सुन्या छ। अलि अगाडि आएर बोलिदिनु होला, आवाज सुन्या छैन।
Good evening, सबैलाई. Today I am going to present thyroid disorders.
राजु अलि अगाडि कम्प्युटर अगाडि आइदिनु पर्ला।
अहिले कस्तो सुन्या छ? अहिले
अलि भोल्युम बढाउनु पर्ला।
Good evening, respected teachers, seniors, my friends and juniors. Here I am going to present thyroid disorders today. Even though the topic is so huge and big, I am going to, especially I am going to present over hypothyroidism, approach to the management of hypothyroidism, along with hyperthyroidism, and its approach of management. Not only this, I am also going to present over thyroid neck swelling along with thyroid nodule and its approach, and I'll be concluding my presentation. For the first, as you already know, the thyroid gland, the thyroid gland is the endocrine gland. This is situated over the to the trachea, just above the suprasternal notch and below the cricothyroid cartilage, and this is bilobed gland connected by smooths at the middle, and this produces especially from the thyroid gland, it produces triiodothyronine T3 along with tetraiodothyronine, also known as thyroxine. And for this, there is the process of synthesis of thyroid hormones inside the thyroxine through the feedback mechanism, especially with the homeostatic feedback, negative feedback mechanism is done by this T3 and T4, free T3 and T4 in our body. And in this process, the iodine oxidation along with organification, along with after the organification, there is a coupling of iodine and formation of the tetraiodine and triiodine thyroid hormone, and through the exocytosis, it comes out of the thyroid gland, and most of the about 99% of T4 along with T3 is bound with plasma protein, especially only 1% of the T3 and T4s are free, and among them the T4 is very tightly bound with the plasma protein thyroglobulin, and so even though the production of T4 is much more 20% higher than T3 in the thyroid gland, but in the free unbound form, the T3 is high. The first topic is hypothyroidism. Whatever the causes, if there is a decrease T3 and T4 unbound free T3 and T4 hormone with increase in thyroid stimulating hormone from the pituitary gland, this is known as hypothyroidism. There are so many causes, but the causes are divided into primary and secondary. Especially primary means the problem is in the thyroid gland, and secondary means there is problem in the either hypothalamus or pituitary or feedback mechanism. So regarding the causes of hypothyroidism, the first one is autoimmune. There are Hashimoto thyroiditis, spontaneous atrophic hypothyroidism, hypothyroidism with Graves' disease also. There are also iatrogenic causes like after the iodine ablation and after thyroidectomy, or the patients who is having carimazole, methimazole, propylthyroid, uracil, amiodarone, or lithium. Similarly, transient thyroiditis, especially the viral thyroiditis, also known as de Quervain's thyroiditis, along with postpartum thyroiditis also. And one of the most common cause in mountaineer region is iodine deficiency. But sometimes, if we look, when there is iodine deficiency, then there could be the hypothyroidism. But paradoxically, if we take more iodine chronically, then at that time also, paradoxically, there might be hypothyroidism. Uh, and congenital, like there might be the aplasia of thyroid gland, this hormogenesis, along with infiltrated disease like amyloidosis, Weil's thyroiditis, and cyberitis. And the secondary cause could be TSH deficiency. It could be through the pituitary tumor, pituitary adenoma, or there could be the Sheehan syndrome, or sometimes radiations in the pituitary also cause TSH deficiency. In most of the time, hypothyroidism is much more on the female. It is about 1:6 ratio in male female ratio, and uh, uh, for the hypothyroidism, which screening test will you do now? Actually, in hypothyroidism, there are so many things regarding the hypothyroidism with normal TSH, or hypothyroidism with elevated TSH, or sometimes the hypothyroidism could be subclinical also. So the main thing is we have to measure the TSH, and after measuring the TSH, either the TSH is elevated or normal. If the elevated TSH is found, then we should measure the free T4. I have already mentioned that we are talking about free unbound thyroxine. This T4 means tetrahydrothyrronine, also known as thyroxine, and this is much more bound with 99% of the T3 and T4 are bound with plasma protein, but the free one, biochemically and biological, this works as a functional unit. So if there is low T3, T4, then it could be the primary hypothyroidism. The cause is at thyroid gland. So after that, we should have to do the thyroid peroxidase. The thyroid peroxidase, these enzymes in the follicular cells, this helps to oxidation along with organification of the iodine, so that the iodine can get through the pendrin into the colloid. So thyroid peroxidase, if thyroid peroxidase antibody is positive, then or negative. If it is positive, then we can say this is Hashimoto thyroiditis, and we have to replace the thyroxine. But if the TPO is negative, then we should have to rule out other causes, other primary causes of the hypothyroidism. Along with, if the free T4 is normal, then as you know, the TSH is high and T4 is normal. So this could be the subclinical hypothyroidism. I'll be talking on subclinical hypothyroidism in subsequent slides. For this, we have to do the TPO antibody again, and if it is positive, we should have to replace the thyroxine. Otherwise, we should have to follow and only. In other hand, if there is normal TSH, then we should have to think about the pituitary disease. So if you suspect pituitary disease, uh, if we don't suspect pituitary disease, then we don't need any test. But if we suspect pituitary disease, then we have to again measure the free T4, and if it is normal, then no need of tests. But if low, then it could be the sick thyroid syndrome, or there could be the drug effects, other drug effects. The sick thyroid syndrome is a acute severe illness. There could be TSS normal, but T3 or T4 could be decreased, or in other hand, sometimes there could be the increased TSS, but T3 and T4 could be normal. But underlying thyroid disease, there is not underlying thyroid disease. Now, the most common cause of hypothyroidism is Hashimoto's thyroiditis or Hashimoto disease, which is also known as chronic thyroiditis or lymphocytic thyroiditis. This is result of antibodies against thyroid peroxidase, and commonly it presents in 30 to 50 years of female groups, and it is there is painless, diffuse, non-tender goiter. Regarding the lab values, there is high TSS and low T4 with anti-TP antibody, along with there might be anti-thyroid binding globulin antibody, and the main treatment is thyroxine, levothyroxine. The cause might be different, and there might be many causes, but the treatment of hypothyroidism is only one, that is replacing the thyroxine T4. So the goal is normalizing the TSS level regardless of cause of hypothyroidism. And regarding the treatment, we have to replace the T4, that is synthetic levothyroxine sodium, 1.7 microgram per kg per day, and which makes around 100 mcg per day. But we have to monitor the TSS level at 6 to 8 weeks after initiating the therapy, or if we change the dose of any doses of thyroxine, then at the time also, after 6 to 8 weeks, we have to again measure the TSS level. In the management of, in the initiation of thyroxine, we have to start the thyroxine low, and we have to go slowly up. And the goal is, as I will mention, to normalize the TSS level. The thing is, we have to make the TSS level at the lower half of the reference range. So, in the starting dose for the healthy patients less than 50 years, we have to prescribe 1 microgram per kg per day of levothyroxine. And in the patients more than 50 years, it should be more than 50 years, and it should be less than 50 microgram per day. This is not 50 microgram per kg, this is 50 microgram per day total. So the dose can be increased by 25 microgram if needed at 6 to 8 weeks intervals by measuring the TSS level. And the starting dose for the patients with heart disease should be very low, that is of 12.5 to 25 microgram per day total, and we can increase 12.5 to 25 microgram per day if needed at 6 to 8 weeks. But in some books, it is mentioned that we can use the thyroxine in alternate day in coronary artery disease and other heart disease. Now, to adjust the dose. The dose adjustment depends on the age, especially in elderly. We have to start half of the dose. In some books, it is written that around 50% less. And in severity and duration, if the disease is severe, then we have to increase the dose. And if it is not severe, then we can also decrease the dose. And with weight also, dose can be adjusted, like 0.5 microgram per kg per day, up to 3 microgram per kg per day. We can give the thyroxine, and we have to be cautious in giving thyroxine at malabsorption, because the dose should be the increase in malabsorption. And if the patient is taking concomitant drug, at that time also we have to adjust the dose. And for the in prescribing the thyroxine, we have to tell the patient that it should be taken on in this stomach for the good absorption. But I have been through different articles. I found that um, one of the article in JAMA, it told that um, it is much more good to give in bedtime thyroxine. And regarding the pregnancy, around 25% to 50% growth should be increased, and it is safe in lactating mother. And as I've already mentioned, in cardiac disease, we can start alternate. The treatment should be started, and it can be given alternate day. And I can say that the patient has improved after having thyroxine. Though it may not the patient may not experience full relief from symptoms until 3 to 6 months after the normal TSH, and the reduction in weight is the first improvement, along with facial puffiness then starts coming down. But the skin changes of hypothyroidism, hypothyroidism, like in hypothyroidism, there is diffuse loss of diffuse loss of hair, that is diffuse alopecia, and other hair changes. It takes time to replace down, and TSH starts showing decrement from the high values and returns to the normal eventually. Uh, uh, while taking the thyroxine, we should have to keep in mind that the thyroxine level is reduced, the absorption is reduced by these drugs like cholestyramine, sucralfate, ferrous sulfate, soybean formula, aluminum hydroxide, along with polystyrol hydrochloride. And we should have to keep in mind that in Marfan syndrome, the dose of thyroxine should be increased. And drugs which affects the metabolism of thyroxine is rifampicin, carbamazepine, phenytoin, phenobarbital, and imidazole. When prescribing the thyroxine, over replacement risks, there is the risk of over replacement. Like after that, after the over replacement, there could be reduced bone density, and it causes osteoporosis also. There could be the tachycardia, arrhythmia, and sometimes atrial fibrillation also. In elderly or patients with heart disease, angina, arrhythmia, or myocardial infarction might get into. And under replacement risks are like uh, continued hypothyroid state, long-term in-organ effects of hypothyroidism, increased risk of hyperlipidemia if we replace the thyroxine load. Now coming to the second topic, this is of subclinical hypothyroidism. As I've already mentioned, there could be the TSH level could be increased, but the T3 and T4 level could be normal without any clinical symptoms. So the cause might be chronic autoimmune thyroiditis. There could be the Graves hypothyroidism, where radioiodine therapy is initiated, and sometimes surgery also. Inadequate replacement therapy for the hypothyroidism can cause soft clinical hypothyroidism also, and the patients taking lithium, especially for depressive illness, there could be soft clinical hypothyroidism. Um, Approach to the soft clinical hypothyroidism. Uh, when there is elevated serum, this is not thyrotropin, this is TSH level. When there is increased elevated TSH level, then we have to perform test to confirm thyrotropin level, TSH level is high and free thyroxine level is normal, and test for the antibodies against the TPO should be obtained, and along with lipid profile. At that time, if TPO is positive, then thyroxine therapy should be started. But if TPO antibodies is negative, and then we should have to measure the TSS level. And if the TSS level is more than 10 milliunit per liter, then we can replace the thyroxine therapy. But if the serum TSS level is less than 10 unit per liter, then at a time we should have to go clinically. If there is symptoms of goiter, elevated total or LDL cholesterol level, if she is pregnant or ovulatory dysfunction with infertility, at that time we can replace the thyroxine therapy. Otherwise, if there is no symptoms, then annual follow-up is sufficient in subclinical hypothyroidism. Now coming to the thyrotoxicosis. First of all, before going to thyrotoxicosis, we should have to know about what is the difference between thyrotoxicosis and hyperthyroidism. Thyrotoxicosis is biochemical and physiological complex when excessive serum level of thyroid hormone are present. It means there is excess thyroid hormone. But in hypothyroidism, thyrotoxicosis that results when thyroid gland overproduce thyroid hormone. It means this is the result. This is after the overproduction of the thyroid hormones. There might be the different causes of thyrotoxicosis. The most common cause is Graves' disease. In hypothyroidism, Hashimoto's, and in hyperthyroidism, this is Graves' disease, with around 80% patients has Graves' disease, followed by multinodular goiter, along with STA, solitary thyroid adenoma, and there could be the thyroiditis like subacute thyroiditis, also known as viral or decorbens thyroiditis, sometimes postpartum thyroiditis also, and there might be the iodine-induced the patients the patient taking amiodarone, or the patients which have taken the radiographic contrast media and iodine prophylaxis program can also sometimes cause thyrotoxicosis paradoxically. In thyroidal source of thyroid hormones like factitious thyrotoxicosis, it means sometimes patient might take artificial or synthetic thyroxine by themselves. There could be the struma ovary. It means the ovary contains the thyroid cells, that is follicular cells. In here, 50% of the ovary contains the thyroid cells. So one is struma ovary, and sometimes there could be the TSS induced, like TSS secreting pituitary adenoma. There could be the choriocarcinoma and identiform mode, because alpha subunit of beta SCG is similar to the TSS1, and there could be the follicular carcinoma or sometimes metastasis. There are some non-specific laboratory abnormalities in thyroid dysfunction, but this is not useful in differentiating the diagnosis. But if we suspect thyrotoxics or hypothyroidism, at that time we can send these lab like serum enzymes, raised alanine aminotransferase, GGT, ALP, and there could be the bilirubin could be raised. There might be the hypercalcemia, sometimes glycosylceria. In case of hypothyroidism, the total CK could be raised. There might be the aspartate aminotransferase, lactate deadenine is also slightly raised, and hypercholesterolemia along with normochromic, normocytic, or macrocytic anemia or hyponatremia could be seen. Now coming to the approach to the thyrotoxicosis. When the level of TSH is decreased and the free T3 and or T4 level is increased, at a time we have to look the patient clinically. And clinically, if it is like thyrotoxic, then we have to go for the features of any thyrotoxic, especially Graves' disease. And if it is not, then it could be due to the sick euthyroidism. I have already mentioned in hypothyroidism also. um, the in sick euthyroid syndrome, this is acute severe illness, and the TSS and T3, T4 level are abnormal. But underlying thyroid disease, there is no underlying thyroid disease. So, because it doesn't need any replacement therapy treatment, so we should have to repeat when acute illness has resolved. Because in acute illness, in acute trauma, at a time also uh, sick euthyroidism can be seen. So clinically, if there is thyrotoxic, then we have to go for the features of Graves' disease, because 80% of the patients might have um, hyperthyroidism regarding the Graves' disease. So we should have to look for the diffuse goiter with blue or not. There could be the ophthalmopathy. There could be the dermopathy like petechial myxedema, and there might be the positive TSS receptor antibodies. So if it is present, then any features of non-Graves thyrotoxicity or not, we have to rule out, like less than 6 months pregnancy, neck pain, or flu-like illness. Um, is the patient having drugs like amiodarone, or either the patient is having synthetic thyroxine? Is there any palpable multinodal goiter or not, or solitary nodule? Then, if it is there, then thyroid scintigraphy should be done. But if clinically, if it is not as Graves' disease, even though we should have to go for the thyroid scintigraphy. On the thyroid scintigraphy, uh, this is uh, this is done by the iodine isotopes of 123, and we can look the uptake of the iodine by the thyroid cells. Like low uptake thyrotoxicosis, if there is present, then it could be the transient thyroiditis, or could be extrathyroidal thyroxine source. And if there is only one patchy uptake, then this could be a toxic adenoma. And if there are sparse patchy abscess uptake, then it could be the toxic multinodular goiter. And if it is diffuse uptake, then it could be the Graves' disease, which is much more common. So, regarding the natural history of thyrotoxicosis of Graves' disease, here you can see in A and B, the majority, around 60% of the patients have either prolonged periods of thyrotoxicosis or fluctuating, uh, fluctuating severity, or periods of alternating relapses and remissions. But it is the minority who experience a single short live episode followed by prolonged remission. But sometimes there could be the hypothyroidism also. Now coming to the treatment options of the hyperthyroidism, there are four options. First one is symptoms relief medications. Second one is anti-thyroid drugs. Third one is radioactive iodine treatment, and another is thyroidectomy. The first one is symptoms relief medications. Regarding the hyperthyroidism, the first step is to rehydrate the patient, and we should start the patients with beta blocker, uh, and if especially like propanol or metoprolol. But if beta blockers are contraindicated, like rate limiting calcium channel blocker like verapamil can be started, and we should have to treat the arterial fibrillation, which is common in hyperthyroidism. Here you can see the methimazole and propyl difference between methimazole and propyl thyroid acid. Uh, in important consideration in efficacy, uh, methimazole is very potent, whereas PTU is less potent, and the duration of action is long acting in methimazole, whereas short acting in PTU. In pregnancy, the metronidazole is contraindicated, whereas PTU is safely given. And mechanism of action, both the metronidazole and propylthiouracil block the iodination and coupling. Iodination means uh, the inside the follicle cells, the inorganic iodine is organified through the oxidation iodine and iodination, and inside the colloid, the iodine is coupled from one to another so that the mono and three different mono mix for tetra, and uh, whereas divalent MT2 is coupled for tetra tetra uh, tetraionothyroxine, which is also known as thyroxine. And another conversion of T4 to T3 is inhibited by the propylthiouracil. This is extra in mechanism of action in other than the methanol. And adverse reactions, there could be the rashes, neutropenia. Sometimes there could be the arthralgia also. And dosage is in methanol 20 to 40 mg OD, whereas in PTU 100 to 150 mg QID. Um, for- there are two regimens in hyperthyroidism. One is titration regimen, and another is block and replace regimen. So in titration regimen, we will use uh, antithyroid antithyroid drug. I will titrate it. But in block and replace regimen, we use high dose of antithyroid drugs along with levothyroxine, and we keep the high dose antithyroid drug constant. So in titration regimen, initial dose is 15 to 20 mg of caribinazole, or initial dose of propylthiouracil is 100 to 200 mg. And the dose can be gradually reduced by looking the 3T4, and we should have to maintain uh, the dose of caribinazole in 2.5 to 10 mg, and the maintenance dose of PTU is 50 to 100 mg, and we have to follow up every 3 months with uh, free T4. In block and replace regimen, the high dose antithyroid drug is given with levothyroxine replacement, because if you give the high dose antithyroid, then the patient might get hypothyroid. So to avoid the drug induced hypothyroidism, we give the levothyroxine. The initial dose of antithyroid drug is continued, and levothyroxine dose is adjusted with free T4 estimation. Now, antithyroid drug therapy, reduction of T3, T4 takes around 6 to 8 weeks, and we should have to check FT4, not TSS, in every 6 to 8 weeks. Uh, and titration regimen, the remission it takes 12 to 18 months in titration regime, whereas 4 to 6 months in block regime, and replace regime. So we should have to follow up the patient every 3 months. Now coming to the radioactive iodine treatment. Here the radioactive iodine, which is iodine isotopes of 131 is used, especially in case of toxic multinodular goiter and um, solitary thyroid adenoma. The radioactive iodine treatment is used, but in some cases, before radioactive in some places before radioactive iodine treatment, they go for the anti-thyroid drug. But like places like in North America, they directly go for the radioactive iodine treatment if they got toxic multinodular goiter or solitary thyroid adenoma. So, grapes not the indications are grapes not meeting with anti-thyroid drug in women who are not pregnant, and the best treatment for the best treatment options, and this is also effective and safe. As I will mention, 131 radioisotopes radioisotopes is used for the treatment, whereas 123 radioisotopes is used for scintigraphy. The dose is 6 to 8 millicuries is given orally, and make patient hypothyroid, and there is no risk of cancer. And in some books there is also some risk of infertility. It is written, but articles has many evidences has told that there is no risk of infertility in taking the radioactive iodine. The contraindication of radioactive iodine is we should not give it for the children, near for the pregnant ladies or lactating mothers, and not for the ophthalmopathy, and not for the smokers. And this is because if the patient is smokers, and if there is Graves' disease, and at that time the ophthalmopathy is much more exaggerated. Another is surgical treatment indications. Uh, if there is a multinodular goiter with severe hypothyroidism in children, at a time surgery is the best option. Pregnant women who cannot tolerate antithyroid drug, large goiter with severe ophthalmopathy, large multinodular goiter with severe pressure symptoms, along with if quick normalization of TFT is required, at a time surgical treatment is indicated, either subtotal or total. Now coming to the thyroid nodule, if you found the thyroid nodule, the thyroid nodule could be the around 95% of the thyroid nodule could be the benign, and whereas 5% is carcinomatous. The thing is, if the patient is having thyroid swelling, and either there is neck pain present or not, from this the algorithm goes on like, if there is thyroid swelling with neck pain, if yes, then we have to go for the radioactive iodine uptake test, and if it is increased, then there could be the microbial inflammatory thyroiditis, like there could be the bacterial thyroiditis. It could be streptococcal, staphylococcus, or enterobacter. Or then, if the RIU is decreased, then it could be viral thyroiditis, also known as subacute granulomatous thyroiditis. But if there is thyroid swelling, but no neck pain at the time, we should have to go through the presenting symptoms. If there is hyperthyroid, then again we have to do the RIU, and if RIU uptake is radioiodine is uptake is increased, then it could be Graves' disease, and if it is decreased, then it could be subacute lymphocytic thyroiditis. Uh, this is where RIU is decreased. In hypothyroidism, there could be the chronic lymphocytic thyroiditis also. So, if the patient is present with thyroid swelling, then we should have to know either the patient is having neck pain or not, because most of the cases who have Graves' disease, they don't have neck pain, but there is thyroid swelling. Whereas if the patient is having thyroiditis, especially viral thyroiditis and bacterial thyroiditis, at the time there could be the thyroid swelling along with neck pain. On the topic of on the basis of thyroid swelling, or if there is a thyroid nodule, then there are some features suggestive of malignancy. We should have to ask, or we should have to rule out these things, like there is higher suspicious history and moderate suspicious history. If the family history of medullary thyroid carcinoma or multiple endocrine neoplasia, if there is rapid tumor growth, especially during having levothyroxine, and if there is a nodule that is very firm or hard and fixed of the nodule to adjacent structures, and if there is paralysis of vocal cords, along with regional lymphadenopathy and distant metastasis, we should have to suspect that disease of thyroid malignancy. Whereas in moderate suspicion, age of less than 20 years and more than 70 years, male sex, history of head and neck irradiation, and if the nodule is more than 4 centimeter in diameter or partially cystic, and symptoms of compression including dysphagia, dysphonia, hoarseness, dyspnea, and cough is present, then this is of moderate suspicion of thyroid malignancy. Here you can see the approach to the patient with thyroid nodule. First, if there is solitary or suspicious nodule, then the first thing we have to go through is check the TSH level. If the TSH level is low, then we have to go for the thyroid scan. Thyroid scan, and in thyroid scan, there is there's two things: hot nodule and cold nodule. The hot nodule is the radioiodine is taken by the follicular cells diffusely, and the hot nodule is less cancerous, whereas cold nodule is more cancerous. So, in hot nodule, we should have to ablate or resect or treat medically. But if there is normal TSH in solitary nodule, then we have to do the fine needle aspiration biopsy. But if the nodule is less than 1 centimeter or difficult to do the biopsy, at that time USG guided biopsy should be done for the cytopathology. And after the cytopathology, and there could be 5 things. Either it could be non-diagnostic, or it could be benign, or cystic, or suspicious of follicular neoplasm or malignant, among which around 70% is benign, and followed by non-diagnostic or suspicious neoplasm or malignancy. So if we do the FNSC and cytopathology, we showed benign, then we go for the T4 suppression or T4 suppression uh, by giving the antithyroid drug, and after that we have to monitor the through the ultrasound scanning, and if it is non-diagnostic, then we have to repeat the biopsy through USC guided, and if it is cystic, we have to again reaspirate and consider USC guided biopsy, and also after meantime we have to follow by USC scanning, and if it is suspicious or follicular neoplasm, then it could be surgery, or if it is malignant, then this is also surgery. So in cystic, and in benign, um, if there is further growth or suspicious cytology, then surgery is the best option. These are my references, Addison's, Bill and Love, and Delson's principle of practice.